So even children may have stroke, and if there are neurological symptoms, some tingling, numbness in one hand, it stays for 10 minutes, go away. Please don't disregard it.
Hello friends and greetings from VLCC and a very good evening to you all. I'm Dr. Anju Ghei, Vice President and Head Preventive Healthcare at VLCC. So our expert panel today is Padma Shri Dr. Mahajan, Founder and Chief Radiologist, Mahajan Imaging Centers, and eminent cardiologist Dr. Dhiraj Bhatia. I am so very delighted to welcome and introduce to you our first panelist for today, Dr. Dhiraj Bhatia. Dr. Bhatia has over 35 years of clinical consultancy practice in New Delhi and has been a senior consultant cardiologist for he's been with Fortis Escorts Heart Institute and Max Super Speciality Delhi, and also he's been honored twice by DMNIMA as the Doctor of Excellence. Good evening, Dr. Bhatia, and welcome to the webinar. And thank you so much for joining us today. It's such a pleasure to have you.
Thank you, Dr. Anju, for the introduction, and thank you all the viewers who've taken time out to be with us.
So the question is that what exactly is wellness, and can we gauge wellness, and what does it exactly mean for people who are obese or overweight?
Right. So wellness actually, you can divide it into two groups. Basically, it's physical and mental. So mental, of course, you have spiritual wellness, emotional, and then social. And I think it starts at a very young age, especially the emotional and the social part. Social is actually really connecting with friends. And it's very important to do that. And it can come with good, self-esteem. And if one doesn't have it, then one becomes a recluse, then plays sports, starts gaining weight. Of course, there can be genetic reasons also, but otherwise, so each thing is important. You work on your spiritual growth, you work on your emotional growth. And I think it's important to start at the school level. So, which some of the schools are doing, they're pushing for that, and that's very important. But otherwise, you just land up with a problem later on in life. And then it's very difficult because you've got all that baggage over the years, which you're trying to, fight against. The other part, the most important is, of course, your physical part. And physical, we divide as physical fitness, activity, and fitness, of course, and nutritional. So those two are very, very important. And then, when somebody comes in, we always, when they're walking through the door, the first thing I try to do is assess him. One is you look at the profile and assess a person. You get so much information from the hair, from the eyebrows, from the eyes, from the skin, from the tongue. Those are general physical. But having said that, since we are really into weight gain and obesity, then we look at things like the body composition analyzer. So the BCA is very, very important. It tells you how much water there is in the body. It tells you how much fat there is. It tells you segmental fat distribution. So you can work on those areas scientifically. And that's what they do at VLCC. And a lot of you must be wondering that that is very, very simple. If you don't have a pacemaker and you're not pregnant, it's very, very simple to get this thing done. And you get a lot of information, and then you work on that information, and then you decide what kind of approach has to be taken for weight loss. Second is, of course, you need the parameters. You decide by BMI, which is the gold standard, body mass index. And now we, like you were saying, that we were part of the core group with the All India Institute. So basically, we changed the BMI from 25 for Asian Indians to 23. So why did we lower it? Because Indian Asians are more prone to cardiovascular disease, which means strokes, heart attack, diabetes. So, we found that even with 24 BMI, they were having a problem. So therefore, it was lowered to 23. Similarly, we have a tendency for central obesity. And central obesity is really very rampant. You land up at the Delhi airport, you'll see everybody there with a paunch, from the customs officer, the passport guy, the porter, they're all standing with it. All of us, actually. So this is, I think, been a genetic mutation. And that's what probably Dr. Mahajan is going to, dwell on, and how to move in that. They're moving in that direction slowly and surely. So that really gives us a lot of clue. So this is simple for the viewers. You go home, or take your tape and see. For women, the cutoff is 80 centimeters, no more. right? And for men, it should be 90, maximum 90. In fact, they're saying 85 now, but that's a little stringent, 90. So 80, 90, that's it, 80, 90. So you must keep it below that. That's very important. Then we have waist by um, height ratio. It should be waist by, so your waist should be less than your height. So it should be less than 0.5. So like that, we have a lot of parameters. Then physical, we have a blowing test, like you blow the candle out at a certain distance. Then you have your pulmonary function test, which will tell you exactly. There are many ways you can really go ahead. Then about the health, we look at various things like ultrasound for fatty liver, a lot of blood tests. So then we go into those, by and by. So
Right.
it's a very
Right.
large and vast topic, but I just try to touch on a few things.
Yes,
So
but this is very important, doctor. The waist circumference, and the WHO has already given heads up to this, that the waist circumference is the most important parameter that one should look into, which prevents the further risk to various diseases. And 80-90 formula is so easy to remember, right? And simple thing is that your waist should be less than half of your height. All right. So let's go further, doctor. What happens if obesity is left untreated? Uh, there are so many complications we are hearing about these days. So we'd like to know
so
that.
it starts off simply like you start having high blood pressure, hypertension. Then you start having your cholesterol starts creeping up, which we say hyperlipidemia, and then triglycerides, which are really connected more with carbs than fat. Then your good cholesterol comes down, your HDL. Then cardiovascular diseases, the dreaded complication, or strokes and heart attacks. So those are the ones which are on top of the list. Then, of course, you have pre-diabetes, diabetes, metabolic syndrome. A word about metabolic syndrome. So metabolic syndrome, there's a criteria. You have 3 out of 5, which means you have metabolic syndrome or syndrome X. Now, this is very important because if you're suffering from metabolic syndrome, the chances of cardiovascular disease go up by 20%. 20. So if you look at the bar diagram, it's actually 20 means 1 in every 5. It's very, very high. So, and they're just these simple parameters. One is central obesity, which we just said 80-90, 80-90. Second is hypertension, right? Third is high triglycerides. Fourth is low HDL. And the fifth, the demon, which is causing all this, is high insulin. So you have a fasting sugar somewhere between 100 and 126, which is the pre-diabetic range, or a HbA1c from 5.7 to 6.2. So charity begins at home. If your mama or papa or uncle you should get these checked. Get the lipid profile, look at the triglycerides, look at the HDL, not cholesterol. This is metabolic syndrome. You look at the central obesity, then you look at the hypertension, simple blood pressure. These are simple things to do. And you look at the fasting sugar. If 3 out of 5 are positive, then you know you're in trouble, and sudden heart attack and sudden death. In the old days, they used to say, Babuji ne bula liya, Babaji ne bula liya. Now you know that there are scientific parameters by which. So metabolic syndrome, there's a lot of work going on. And we published some papers on this, and it's very, very same thing, there's connection with PCOS with this. Then, of course, quickly, there are others like a lot of musculoskeletal problems like cervical spondylosis, backache, lumbar spondylosis, or osteoarthritis of the knees. They start giving away. And then carpal tunnel syndrome, then gout. There are many, sciatica, there's so many. They're just intervertebral disc prolapse. So, your disc problems. So, one goes to the other. Then sleep apnea, obstructive sleep apnea. You're never, ever going to lose weight if you have sleep apnea. So you should always check that out, because if your oxygen is falling, your stress hormones are coming out. So it's very important if you're snoring to get your sleep evaluation done. Then, of course, you have cancers, various types, nearly all, like Dr. Harsh was mentioning that day, nearly all cancers are linked to this. And a lot of other, other issues. But these are the main. Of course, you can have gallstones, you can have acidity, your asthma can get worse, your lung function test can get worse. Almost every organ gets hit. So that is why we were very keen that Dr. Mahajan come here today, because he is working a lot on all of these, each and every one. He'll be able to give us a beautiful insight into it. And I think I've spoken enough. We should let our main speaker now start. And you can, I'm sure you have a lot of questions for him. And I think let's get cracking. Thank you.
Thank you so much, Dr. Bhatia, for providing very useful insights for our viewers, and especially those fighting excess weight and obesity and want to avoid the complications. So now, going forward, we have to know how can we diagnose or assess these complications if there are any. And so I'm very pleased to now introduce our special guest on the panel, Dr. Harsh Mahajan. Dr. Harsh Mahajan has been awarded the Padma Shri, we all know, in 2002, and he's a graduate of MAMC Delhi, MD Radio Diagnosis from PGI Chandigarh, and fellowship in MRI from MD Anderson Cancer Center, Houston, Texas, USA. Wow. Welcome to the webinar, Dr. Mahajan, and it is such a pleasure to have you with us today, and thank you so much for joining us.
Thank you so much for having me here, Dr. Ghei and Dr. Bhatia.
Let me start with the first question. Dr. Mahajan, our fast-paced lifestyle, stress and pollution and everything comes with increasing risk of heart disease and other diseases. How can we assess our risk, especially, and prevent these heart diseases?
That's a great question. It's also something which all of us, even we as doctors, want to know about our families, about ourselves. And so I think we know now that genetics plays quite a big role in many of these chronic diseases, in the non-communicable diseases like diabetes, heart disease, strokes. And so the first thing is that we need to know whether there's any degree of heart disease in the family, parents, siblings, uncles and aunts. Also, you've talked about cholesterol, that's important, and hypertension. These are things which we know about our families, which our parents may be on antihypertensive drugs, blood pressure high hai, cholesterol high hai. So first thing is awareness within your family, and then coming to yourself. And now it is known that right after a child is born, these changes start. It's not as if it's only at 30, 40 years that these changes start. They start pretty early. So to be aware is most important. After that, to rule out, I think the simplest thing is blood tests, with which you can come to know, you do a lipid profile, blood sugar, kidney function test, liver function test. There's a set of tests which can very easily point out whether you are in the normal range or there is something which is abnormal, especially as regards lipid profile, total cholesterol, and more importantly, LDL, which is the low density cholesterol. With that, if we know, some part of this will be controlled by your genes. But with our diet, with the exercise that we do, our non-sedentary life, we can actually correct some of the problems that we've got through our genes. As Dr. Bhatia told about, most of us have truncal obesity. लातें पतली होंगी और पेट में, we'll be having tummies which protrude, and that's very common. Here also there was, a concept of what they call was the thrifty gene, that over the thousands of years, because of deprivation of food and all that, our bodies actually learn to store.
I think we lost Dr. Mahajan. He'll be back, I'm sure. There must be some error there. We'll wait for a minute.
Do things in moderation. We can actually counter all of these things which lead not only to heart disease, diabetes, strokes, and obesity. Obesity, like Dr. Bhatia told, it sounds strange, but it's a high risk for cancer also. So that is one. Number two, so these blood tests. Number two, at a certain stage in life, and depending on the risk factors, you may want to get an ECG done, you may want to get a chest x-ray done, you may want to get an abdominal ultrasound done. These are simple tests through which a lot of information can be obtained. A liver ultrasound can show us whether there's fat in the liver, and we know now that somehow people think, oh, grade 1 fat is normal. Well, the surprising part is that now we know even grade 1 fatty change in the liver over time may result in cirrhosis, something which we used to think comes either from viral infection or from alcohol intake. So these simple tests also, they can tell you about your kidneys, they can tell you about the pancreas, spleen, and most importantly, both in men above a certain age, they show you the prostate, whether the prostate is enlarged or not, whether it's causing any obstruction or not. And in ladies, they can show you the uterus, the ovaries. So these, once a year, probably after the age of 35 years, would be prudent to get these simple tests done. Then based on your risk profile, you may want to get an echocardiography done, which is an ultrasound basically of the heart, which shows you how the heart is functioning, how the heart is pumping, whether the chambers are fine, whether the blood flow is fine or not. In case one finds some problem, then, that can be addressed. Like you very rightly said, and we've read in our school and be told time and time again, prevention is better than cure. Also, we know now prevention is much cheaper than cure. So a little amount of money is spent on a health check, and a proper health check can go a long way in early detection of disease, in disease prevention, and if we detect early, then it can be taken care of. Now about heart disease itself and coronary artery disease, the arteries which supply blood to the heart, there in the early 2000s, a CT scan machine came which was able to non-invasively show you blockages in the arteries. And I'll show you a few pictures of that. This CT angiogram came in the early 2000s, and over the last 20 years has really caught on because it can really prevent heart attacks, because you can diagnose even deposits of fat within the arteries, the narrowing of the arteries non-invasively. It just requires one injection intravenously. Whereas an invasive angiogram, you have to put in, cut in the thigh or in the arm, then you put in a wire over that, you put in a catheter, reach the heart. Here, just one injection in the vein, and you can see the heart very well. I'll show some pictures. And this may be appropriate in high-risk asymptomatic individuals above 45 years of age. Actually, over these last 20 years, we brought that down to 40 years, and especially those at high risk, those who have family history of heart disease. Hyperlipidemia means raised cholesterol, diabetes, high blood pressure, obesity, and sedentary lifestyle. And especially with pollution that we live in most of the large cities, and even some of the small towns of this country, even that becomes a risk factor. So those at higher risk need to get it done early. Otherwise, one CT angiogram at 45 years of age can actually give you a good idea. If it's normal, then it can be repeated after 5 years. You don't need to do it again very frequently. And if we do find some plaque, like I'll show you, these are, from 2004. It was a 16-slice coronary angiogram done on a 16-slice CT. And even at that time, this machine cost 4 crores. You can imagine, that would be equivalent to about probably 15 crores of today. But you can see the heart, you can see these coronary arteries, which supply blood to the heart very, very nicely. And this is a Time magazine cover from 2005, which actually brought home this information not only to physicians at large, but to general public, that CT angiogram has come here to stay, and this can actually stop a heart attack, like it says, before it happens. So this article really did human service. And see, we now have 128 slice CTs. In fact, we have what is known as a dual energy CT, which can give very beautiful images. You can see these are the arteries, and if there's narrowing anywhere, that can be seen very well. That's a picture of one of our machines. One of the problems in the early years was radiation dose, but now radiation dose is very, very low. If I tell you that the radiation dose of a CT angiogram is same as when you fly, or even lesser, as when you fly from Delhi to New York and fly back, it surprises people. They don't think you get radiation when you're up in the air, but you're that much nearer the sun and you're getting radiation. So the radiation dose is very, very low and really not a problem itself. And look at this CT angiogram we were just talking about obesity. This is a patient with a BMI of 45, and we just use 5 millisieverts here. So bulkier the patient, more the radiation you have to use, but only 5 millisieverts. When we started in the early 2000s, we used to use 15 to 20 millisieverts. And for average build patients now, it's 1 to 2-3 millisieverts only. And even here you can see the angiogram shows the arteries so very well. That's another case with a low dose, high risk cardiac CT angiogram, BMI of 37. So it is their genes that are protecting them. They've done everything wrong, but their genes still protect them, but they can only protect you for that long. As you grow older, 50 years, 60 years, what you've done wrong is going to kick in and will cause narrowing. This is just to show that we can do an angiogram. Of course, this is necessary only in certain clinical conditions, all the way from the neck down to the thigh, with angiogram of the heart as part of it. This shows calcium deposits within the arteries, and that is something which is seen very nicely on CT angiograms. And even based on how much calcium is there, we can tell about the possibility of significant coronary artery disease. Also, those who had stents placed for their also CT angiogram can show very nicely. And here you can see this is a patient where you see these two dark lines. I wonder if your viewers can see them. So even though a stent has been placed, there is now restenosis or narrowing occurring within the stent because of whatever were the factors that were there. This is called in-stent stenosis, which is again, so see how nicely, and this is just a 5-minute test. The actual procedure is only 6 to 7 seconds of a breath hold. So very, very easy. Then based on what kind of deposit is there, is it fat, is it calcium, we can even characterize. And I would like to tell your viewers that fatty plaques or fatty deposits are much more dangerous than calcium because they can break and cause a heart attack. And so this is something, even if the narrowing is 20%, 25%, we actually, from the narrowing point, we become conscious and concerned if it is more than 70%. But even if we show that it's 20% and it's fatty, then people can change their lifestyles. If the cholesterol is high, they can bring it down. And with that, you can actually prevent heart attack. So these are some of the tools that are available to us today, non-invasively, we can peep into the heart, peep into any part of the body and tell non-invasively. And this is what is called predictive medicine. And this is where, and we'll talk about it in the context of cancer, where it's very, very important that genome sequencing can play a role to determine heart disease, determine dementia, cancer, who are at higher risk. And we'll talk about that as we go forward.
Sure. Thank you so much. So for the viewers who are at higher risk, more than 40 years old, it's very important to get this preventive check. And now, like Dr. Mahajan said, we have CT angiogram, which is with such low, radiation, and being able to, find out the soft plaque, which is the fatty plaque or the blockage, and even the calcium. So it gives us a good information as to where we are. So going forward, Dr. Mahajan, we hear of so many cases of strokes these days, and this is just an extension of what you just said, the cardiovascular disease now leading to stroke. So how do we screen for risks of stroke? And also, we know that when a stroke is happening, every second matters. So we'd like to hear from you about this.
As they say, time is brain. Millions of neurons are lost every minute when there's stroke. And the risk factors for stroke are nearly similar to those for heart disease, as I've enumerated. And one of the simplest methods of seeing plaque built up or deposits in the arteries which supply blood to the brain is in the neck, the carotid arteries and the vertebral arteries. And that is a simple ultrasound examination, which is called a color Doppler examination, where we can very easily see whether there's any deposit in it, the deposit, how much of narrowing is it causing, it can be seen very well. And if there is more than 60%, and even if someone is asymptomatic, it can be addressed, it can be treated. So more and more over the last decade or so, we call it neo-intima evaluation, intimal thickness. With that, we are able to know whether someone is at higher risk of developing stroke. And again, the corrective measures would be the same. Exercise, dietary, a proper diet. If cholesterol is high, lower the cholesterol, and hypertension, all of those need to be controlled. And in case there is a significant narrowing, then, to evaluate further, we do what is a CT angiogram or an MR angiogram. And I'll just share again with you 2-3 pictures of that. This is a CT angiogram of the arteries in the neck going up to the brain. This here, you can see very nicely, is the common carotid artery, which actually carries blood from the heart all the way up. This is the internal carotid artery, which is narrowed. And also, in this case, we can see that within the brain, this white thing that you're seeing, very white, is calcium deposition within the artery in the brain. So that also very easily, non-invasively, you can see, and then you can take measures. Similarly, you can see this. There is some narrowing here. Again, there may be lipid plaque, there may be calcific plaque, and based on what you find, you can actually see. So this is the major artery coming from the heart and then going all the way up. All seen in non-invasively, takes barely a few seconds to do it. And this is another case, this is a young child, and even children may have strokes. And so here you can see arteries which are abnormal within the brain in this young child, how you can see the arteries filling up and coming from the heart, the blood supply going to the brain and showing it. So even children may have stroke, and if there are neurological symptoms, some tingling, numbness in one hand. It stays for 10 minutes, go away. Please don't disregard it. The TIA, transient ischemic attack, and if we intervene early, then we can reverse the entire process without much brain damage. So in case you feel any member of your family is having neurological deficit, some problem, difficulty suddenly in speaking, weakness one half of the body, it is time to rush to the hospital. Because, like I said, time is brain, and if we rush fast, it can be managed.
It's really, I mean, amazing to know that even young children and youngsters are getting affected by the cardiovascular diseases and strokes, and one has to be very, very careful. And if any symptoms or signs are visible, one must get oneself checked. So going forward, yes, Dr. Mahajan, because of poor posture and obesity, as we have seen in many people, the first thing or most commonly they complain is of low backache and sciatica, which is so very common now. So how do we diagnose and how do we assess it and how do we diagnose and treat them?
See, you would have seen the moment you said poor posture, I straightened up. So one has to be aware. One has to be aware. Again, awareness is the thing. You'll be surprised. You even get devices, which you can attach on the back of your shirt. And if you're stooping or something, it'll warn you. So one thing is, correct posture, the right kind of exercise, muscle strengthening exercises for the back. But if you do have pain in the back or pain going down the back of the thigh, below the knee, into the foot, it can all be, this is called referred pain. And even though the compression is in the spine, the pain may be in the calf or the back of the thigh or the buttocks. And when that happens, generally, you would be asked to get an X-ray done. And invariably, if it is sciatica, then you would be asked to get an MRI done, because it's only the MRI which can show the effect that the compression is having on the nerve and the pain. And based on that, then either physiotherapy, exercises, surgery, depending on the degree of problem. Just pain alone is not an indication for surgery. For surgery, there needs to be some neurological deficit, some weakness in the leg, something like that, which should. Let me share one or two slides again. So this, is a different kind of MRI which I've shown. We have many MRIs in our centers. In fact, in our center at Savjang Development Area, we have, and actually, Savjang Enclave is where VLCC started its first center. I remember ages ago. So this is an open MRI system, and here you can do the MRI with the patient lying down or patients sitting or standing. And those who are claustrophobic, scared of the tunnel MRI machine, they can utilize this. And what the MRI shows is actually the bones. It shows the discs. It shows the degeneration of the discs. It shows disc protrusion or slip disc, as we call in layman terms. And over time, with degenerative change, ligaments also thicken and start compressing. So MRI is actually the gold standard for showing us what is going on inside, the degree of compression, and based on that and on the clinical problem, one can actually determine what will be the line of treatment. And here I would also like to touch upon, a very important aspect, which is of osteoporosis, and especially in women, and especially in women post-menopause. Generally, it is said to be uncommon in men, but we've found in the last 22 years that we've been doing bone densitometry that even Indian men have osteoporosis, and Indian women tend to get just as most diseases occur at a younger age as compared to our Western counterparts. Osteoporosis also happens early, And it's important to recognize this because one of the causes of low backache can also be an unknown compression of a vertebral body or within the spine leading to compression. And for this, we can do, it's a simple procedure called DEXA, dual energy X-ray absorptiometry, and we can do bone densitometry of the entire body, and we compare with normals, and then we can know whether it is normal or there's osteopenia, which is the pre-osteoporotic condition, as well as then osteoporosis. And then we can also look specifically at three areas which are most prone to developing osteoporosis. That is the hip, the lumbar spine, and the forearm. These are also areas which are most prone to injury. So in the elderly, invariably you'll find that hip fracture occurs, and that can lead to a lot of morbidity and mortality. Similarly, minor trauma and you get a fracture around the elbow. And of course, many times we've seen a car going over a speed breaker very hard, and an elderly man or woman sitting inside gets a bump, and the vertebral body in the lumbar spine collapses. So we need to be well aware of it. We need to actually do this test, and this invariably forms a part of the health check, especially for women, and especially who are postmenopausal. But we are finding that more and more women who diet are having osteoporosis. Those who've undergone obesity treatment, they may be losing weight, but they may be also losing calcium. So this is called brittle bones. And so we need to be aware of it. And we get many people who are obese, get their bone densitometry done before and then after they've lost weight, so that they are able to cover up. And with calcium supplements and vitamin D3, which you know very well, this can be overcome. What I would like to say here, that the earliest that you should repeat a DEXA to see whether improvement is occurring or not should be at least 1 year. If you do it very early, the change is so little that we may not be able to pick it up. So don't repeat a bone densitometry test earlier than 1 year, and as much as possible, try to get it done on the same machine where you got the last one did, unless, of course, that machine is not up to the mark. Thank you very much.
So, Dr. Mahajan, I mean, hearing about this open MRI is so it's so interesting, because I've seen young children and elderly, especially, so scared of actually going into the machine, and they had to be sedated and all that. So this is coming as a boon, and also, of course, DEXA for women for osteoporosis.
It's a very comfortable machine.
Absolutely.
Very comfortable machine.
Wonderful, wonderful. Talking of women, Dr. Mahajan, we come to now the cancers and malignancies in women, and it is like exploding nowadays, generally occurring in breasts and ovaries and uterus, and so we would really like to know how they are screened and how they are detected, and so that they can be prevented.
Let's talk about breast cancer, because that's like an epidemic. I think everyone knows someone who's had breast cancer, whether in the family or in friend circle, and many times more than one. And also data of our own country has shown that the chance of a woman living in a city is 2 times the chance of a woman living in a village in our city itself, and the risk factors are all around us, and we know that. Let me again share my screen. Screening in cancer, it is screening, especially in high risk individuals, doing the proper screening to pick up cancer early. We know that if we pick up breast cancer in stage 1 or early stage 2, we can provide a cure. Whereas if it is stage 3 or 4, then despite all the advancements in therapy that have happened, still we will be only able to give a few years. And also chemotherapy and all those therapies are so very, problematic. So screening mammogram is done in women who have no breast symptoms or sign. So we have to also differentiate screening mammography from diagnostic mammography. And mammography is a high resolution X-ray that is done of the breast. A diagnostic mammogram is done in women who have clinical breast symptoms like they felt a lump or who have been called back from a screening mammogram because something was found. Now, screening mammography at what age and frequency in average risk women? Here we are talking average risk women, not those who are at high risk. In US, they start at 40 years of age and do it once a year. In UK, they start at 50 years of age and do it once in 3 years because actually it's all free there, covered by NHS, and they have much lesser machines than what are desirable. In India, I feel, and most people agree with this, we start at 40 years, and really in average risk women, we do once in 2 years, whereas in those at high risk, we do annually. Who are the women at high risk? Those with a known genetic mutation, those having a first degree relative, 20% or greater lifetime risk for breast cancer, then first degree relative who has breast cancer. We should start 10 years earlier than the youngest first degree relative who was diagnosed, but not before 30 years of age. And then those who may have received too much of radiation, and so on and so forth. Then also we've, in Delhi, brought in 3D mammography, which came in about, I think, 8 years ago. And now, initially, 3D mammography was done only for diagnostic mammography, but now has become standard of care for even screening mammography. So the 3D mammography would be the preferred modality. A word about ultrasound. Many times when you do X-ray mammography, the radiologist may want to do a attendant ultrasound also, which is an adjunct. That becomes an additional part of screening, and it is able to show things better. It has some role in differentiating a benign from a cancerous lesion. It is very important for guiding biopsies. It is also the first modality of choice in young women, and especially those with dense breasts. So if someone comes, for screening and is 30 years of age, then we would do an ultrasound first and not a X-ray mammography. Whereas if someone comes with a lump, there also in a young patient, we will first do ultrasound and then we may follow up with the X-ray mammogram. But younger the patient, denser the breast, less clearer is a 2D mammography. That's where even a 3D mammography plays a major role. So here, we have to differentiate screening, which is in those women who have no problem, from diagnostic mammography, which is in women where they feel a lump and then come, and the approach would be somewhat different. So this is X-ray mammogram in one patient where you see this is an intramammary lymph node, otherwise it's normal. Here you see a large mass on the X-ray mammogram. Of course, it appears to have very rounded margins, well defined. So most likely it is not cancer, but we don't know what is inside this. So the role of ultrasound comes here, that it's able to show us that this is a benign cyst. There is fluid inside this, and this is not a solid tumor or a fibroadenoma. So that's the role of ultrasound, apart from guidance for biopsies, which we do in our centers on a daily basis. Now, what happens when you find, on an X-ray or an ultrasound mammogram, a malignant lesion? Then what we do is a MRI mammography, where you're able to see, after injecting contrast, this mass very, very well. It also helps in ruling out masses in the other breast or multicentricity of cancer. At times we found 5 distinct separate cancers in the same breast, or one in one breast and also in the opposite breast. That's where, when findings are not clear on an X-ray or ultrasound, that's when MR mammography is done before a patient is taken up for surgery. So that's in the later stage. And then finally, also, it has a role to play in those ladies who've had breast implants being put, because at times they may fracture, they may, there may be complications there, and MRI is a very valuable tool there. Also, there's some evidence that these silicone implants may increase the risk of developing cancer, and that's where screening is better done with MRI than with the other modalities that we have. I thought I'll also bring that to the notice of your viewers. And then when cancer is found, one may do also what is called a PET scan, which we do in our centers. And there you're able to see whether the disease is confined to the breast or there is spread, like in this case, there's extensive spread that we see to the bones in the spine, in the sternum, the chest bone, and in the ribs. So all these modalities are available, right from screening to diagnosis, putting in a needle, getting the pathology, and then based on what we find, if it's benign, you stop there. If it is cancer, then you go ahead and do accordingly. So this is something that is there for breast cancer. And breast cancer, like I said, has become a scourge. We need to be aware, and we must do screening mammography. We have the best technologies in the world available to us in this country. And I know you have your guests who are viewing us from across the world. Please, it is a must to do this. Even those at average risk should do it once in 2 years at the very least. If you're in the US, your insurance company will fund it for you once a year. And if you have a lump, I mean, it's so bad, that ladies just keep waiting. And they found a lump 1.5 years ago, and it's fungating and so large by the time they come to the doctor. Please don't do that. That is my sincere request.
Thank you so much, Dr. Mahajan. So,
also here, if I may add, Dr. Ghei,
right,
is the role of genome sequencing. We've all been hearing of genome sequencing for COVID. That is how we come to know that one strain has changed and become another strain, from the Wuhan virus to the Alpha to the Delta to the Omicron. That we are able to see only using genome sequencing. And it is also very, very important in cancer, because those who have a specific mutation, we now know that many cancers have a genetic predisposition.
right.
And using genome sequencing, we can actually, and a little bit of blood, that is all we need. In a family, if your mother has had, and we can tell your risk of developing cancer based on whether there is a mutation called a BRCA mutation or not. And several years ago, Angelina Jolie also made this very famous, because she was at high risk of developing breast cancer. So she had bilateral mastectomy done, and of course, remodeling of the breast was done at the same time. So this is another very important fact, which is part of what is now known as predictive medicine and preventive medicine, where if you know, then whether it's colon cancer or prostate cancer or lung cancer or breast cancer, ovarian cancer, you can do screening much more stringently than you would otherwise.
So very true. And you just mentioned about the COVID thing, and that brings another question to us that many people these days are suffering from flu, and the fear of COVID is uppermost in their mind. So, do you suggest getting tested for COVID in each case, and do you suggest also a fourth dose of vaccine as preventive nowadays? There's a lot of
Uh, let,
confusion.
let me take your first question. I think today, it's a mix of COVID and other viral illnesses which, give us a cold, cough, and all of that. So, but still, at the back of your head, you have to remember that COVID hasn't gone, it's still around. So, I would say you isolate from your family, because you may have some elderly in the family who, if they get it, even though what we have predominantly now is the Omicron BA 2.75.2, it's a very long name, and it's generally mild, and but still, if the symptoms come, then there is no harm in being tested. But more important than testing is isolating yourself from your family and friends. And as regards the fourth dose, I think at least in our country, it is not recommended as yet. The booster dose is what is recommended, and for the fourth dose, I think we can wait. We have pretty robust immunity. The numbers are going down. We've come down to numbers which were, even WHO recommends that probably this disease is waning, because the global numbers are also lowest today than they were when it actually started. So we can wait for the fourth dose, and if necessary, and also, the vaccines that we have today have been, made against the ancestral Wuhan virus, whereas now newer vaccines are coming, which will be against the Wuhan as well as the Omicron. So they will be much more effective against whatever future mutations are going to occur. So I think we wait and watch and follow a government protocol as far as the fourth dose goes.
And I think for everybody, he's right. If you're young, go in for an ultrasound. If you're worried about radiation, and then, especially for screening, and then later on, of course, then the mammogram is there. And for diagnostics, you have no choice but to do a mammogram, and you have to do. So a lot of people are asking if there's a family history, and there's a family history of breast cancer. And they're saying that you also have been diagnosed with breast cancer in one breast. Should both the breasts be removed? Supposing the genome testing is not available to them. And I think you answered that when you talked about the actress, and I think that is fair
Angelina
enough.
Jolie, yeah.
I think we need to remove both. That's what I would take.
Yeah, Dr. Bhatia, genome testing is available in our country. In fact, we at Mahajan Imaging do it, and you no longer need to send samples to the US or to Europe.
What is the
And
cost?
and the cost is very low. It depends on what exact
Specific you're asking for.
test is to be done, but
Right.
it varies. I mean, when I say low, it is low in comparison to what it used to be, anywhere between 20,000 to a lakh. But when it's a targeted test, 21,000 is what it costs, whereas it used to be costing in lakhs earlier.
Yeah. And I think when it's a question of your life, then, especially that much cost anybody would want to take, because, at least it gives you clarity if you have to remove both breasts or not. So that is one
Yeah, if
issue.
we talk about cost benefit ratio, then it's
Exactly.
heavily weighted in favor of
Absolutely.
benefit.
Yeah.
For your own health and for a serious disease, if you have that BRCA mutation and you are at higher risk, then you need to be much more careful and catch it early in stage one.
Right,
Another
absolutely.
question they were all asking was that, you mentioned that you could have grade 1 fatty liver, And then before it, it just goes into cirrhosis, which is very true. So what, and now recently, the fibroscan has come up, and even you have one in your center. So just a couple of lines for general public, so they understand what a fibroscan is and how it complements the ultrasound and how
Yeah.
important it is.
So, when we do ultrasound, we get and look at the liver, we get a gross idea of fat deposition within the liver. Whereas with this newer technique, which is called shear wave elastography, uh, we are able to quantify fat in the liver, as well as look at, from fatty liver, in certain cases, it may go into an inflammatory stage and then go into fibrosis. We have grade 1, grade 2, and grade 3 fibrosis, and then it goes to cirrhosis. So, all of these stages, to a large extent, ultrasound, and these are, specialized machines, are able to tell and also able to show the difference. Now, the gold standard here also for fat quantification, as well as for liver elastography and fibrosis quantification, is MR elastography, MRI, which we do in two of our centers. So, in those where one is not clear on ultrasound, then MR is available to us for problem solving. Otherwise, ultrasound elastography, shear wave elastography, as we call it, is a step before that, before MR, and MR may not be necessary all the time, and a step after a routine ultrasound.
And last question, we are seeing there's a young girl, medical student, and she's saying we are seeing cancer at a younger age group. My feeling is we're seeing it was always there, but the diagnostics are better. So we are picking it up faster. But having said that, yes, we are going through, a lot of pollution in big cities in particular, a lot of insecticides in the food. So that must be contributing. So she was basically inquiring that is there something you would suggest what we should do to take a lot of vitamins? And I don't know. I think Indians take too many vitamins as it is, and I don't know how far it's going to help. Maybe some antioxidants.
I don't think there's any medical evidence that
Hmm.
vitamins can ward off these.
What of
Of course, a healthy lifestyle, normal body weight, exercise, all of these help. And the ultrasound is a very good tool, especially for a woman. And let me share these final slides, which I thought, since you asked this question, let me share these, where ultrasound and gynae malignancies, and this really has become virtually an extension of clinical examination, which a gynecologist does. Is low cost, low risk, high patient acceptance. We do it from the abdomen to look at masses, and at times for smaller minor things, transvaginal ultrasonography is done, and color Doppler can help in differentiating benign from malignant. And really, this is, endometrial hyperplasia, cystic, which we can see in this case. And then MRI can also be very useful. This is again endometrial hyperplasia and polyps, which one is able to see also, very nicely. This is a cancer. You can see this whole thing extending throughout the uterus on a MRI. And then again, the final, whole body examination is a PET scan, where you're able to see the entire body and see spread of disease. This is where the cancer actually is confined. So, you know, uh, and an answer to the doctor who asked, I think it's a combination of both.
I think
It's
lifestyle is very
better diagnostic facilities, yes, definitely, but also the fact that these numbers are genuinely increasing as a percentage of the population also,
yeah.
and the very fact that breast cancer is double in the cities as compared to villages, that itself speaks for itself.
So thank you all for attending our webinar and guiding our conversations with your wonderful questions. And thanks also again to our panelists, Dr. Harsh Mahajan and Dr. Bhatia,
Thank you.
for all our learnings today.